The following is a short review of pediatric lower extremity pathology. We will be taking a voyage through lots of disparate stuff that I want to make sure you guys have at least seen as you're studying for the boards. These are the topics that will be covered. Let's first start with proximal focal femoral deficiency. This is a large spectrum of disease and can be anything from a slightly shortened extremity to an extremely shortened extremity. It occurs because of a mutation in the sonic hedgehog gene, which involves the limb bud. It can be bilateral in 15% of cases and should certainly be on your differential diagnosis when you see children with short stature. There's a high association with other conditions. This does not just affect the femur. They can have a fibular deficiency, a deficient ACL, knee contracture, as well as coxivara. The percent of shortening that they have remains constant with growth, unlike some other conditions, and their thigh can appear flexed, shortened, abducted, and externally rotated. The treatment is largely based on the projected leg length discrepancy at maturity, as well as the hip stability and the presence of a foot. Although there are many classification systems, the one used most often is the Aitken classification, using A through D. The most important parts are whether or not the femoral head is present or absent, and the morphology of the acetabulum. If you do not have a stable hip, you will not be able to appropriately lengthen that leg. Treatment options. Observation is rarely enough unless it's a very mild deformity or if it's bilateral. Prosthesis can be put at the end of the limb without any surgical procedure. This typically is not as well tolerated. One might consider limb lengthening when the discrepancy at maturity is predicted to be under 20 centimeters. In order to lengthen, as previously mentioned, the child must have a stable hip and a functional foot. It's recommended that the length of the femur be greater than 50% of the opposite side. These are typically Aitken A's and B's, and again, you cannot lengthen with an unstable hip. Knee arthrodesis with foot ablation is another surgical option. This is typically undertaken when the ipsilateral foot is proximal to the contralateral knee, and the prosthetic knee cannot be below the contralateral knee, or else you'll have difficulties with gait and with fitting. The craziest procedure that everyone wants to do as a resident is the Van Ness rotationplasty. This is a good option in children where the ipsilateral foot is at the level of the contralateral knee, but it does require good ankle motion. The ankle will function as your new knee joint. So if your ankle is very stiff, this is not an option. This can also be undertaken in Aitken C's and D's. Finally, amputation. When the femur length is way less than 50% of the opposite side, you want to try to amputate through the joint to avoid overgrowth. Moving on to hemihypertrophy, this refers to any asymmetry greater than 5% between sides of the body. It can involve one limb or the entire side of the body. It's often idiopathic, but for the purposes of examinations, you want to rule out syndromic causes. Surgery is typically only indicated for leg length discrepancy if it gets big enough. In most cases, there are no orthopedic surgical procedures to help the bulk or width of the leg. You want to rule out neurofibromatosis. You want to rule out Beckman-Weidman syndrome, which is typically characterized by a very large tongue, some glucose abnormalities, and microcephaly. This is typically evident at birth. Klippel-Trenaunay syndrome, which is characterized by avascular malformations on the larger leg. Again, children will typically have this diagnosis by the time they come to see you. And also Proteus syndrome, which is characterized by bony and soft tissue tumors on the large leg. Leg length discrepancy is quite common. Up to 2/3 of adults have a 2 centimeter leg length discrepancy, and most need no treatment. There's many ways to track this, but for the purposes of the examination, the easiest to remember is the estimation method, which you should all be familiar with. This assumes that boys grow until 16 and girls grow until 14. And it takes into account that the proximal femur grows at 3 millimeters per year, the distal femur at 9, the proximal tibia at 6, and the distal tibia at 4 millimeters per year. In terms of treatment, in children with less than a 2 centimeter discrepancy, you can either put them in a shoe lift or simply nothing. For those with a projected discrepancy of 2 to 5 centimeters, you want to discuss with the family epiphyseadesis on the contralateral side. This typically occurs through the distal femur and proximal tibia because these are the areas of greatest growth. Any discrepancy greater than 5 centimeters should take into account both lengthening of the short leg as well as contralateral epiphyseadesis. And if the discrepancy at maturity is predicted at greater than 20 centimeters, one wants to have the conversation with the family regarding amputation. Full-length films are a must. The EOS evaluation will not be an answer choice, and so for the boards, one should pick CT scanogram if available. A bone age film, which is a PA X-ray of the left hand, is necessary for full assessment, and in the cases of trauma and physeal bar, a bar excision is recommended when less than 50% of the physis is involved and the child has greater than 2 years of growth remaining. Congenital knee dislocation, this really ranges from quite flexible to rigid. The importance of this disorder, much like many in this talk, are going to be the associated conditions that you cannot miss. It is very rare for congenital knee dislocation to be idiopathic, and it's typically associated with spina bifida, Larsen syndrome, arthrogryposis. 50% of these children will have a DDH, most notably a dislocation. You must treat the knee first, as it is physically impossible to get a child in a Pavlik harness with a congenital knee dislocation. Most are able to be treated non-operatively with serial casting. They do, however, require surgical intervention if you cannot get them to 30 degrees of flexion after a full 3 months of casting. And most of these children who go to the operating room require a VY quadriceps plasty. Let's talk a word about rotation because this can get you out of trouble when answering questions. It's important to know what's normal, and you guys should know this well from the PEDS rotation. It is quite common to see varus overall alignment until about the age of 18 months to 2 years. They then go into a valgus and finally to their adult alignment at about the age of 7. Infantile Blounts is quite common in early walkers. It's often bilateral. Their distal femur is normal, and we use the Langenskjold classification, which you can see to your right, to talk about the extent of physeal damage and possible physeal bar. On x-rays, it's standard to measure the metadiaphyseal angle. Metadiaphyseal angles of less than 10 are normal and greater than 16 are indicative of infantile blounts. Metadiaphyseal angles of greater than 16 have a 95% risk of progression. Most can be treated non-operatively in the KAFO of your choosing. This unloads the medial joint. Bracing is appropriate in kids with early stage infantile blounts who have lateral thrust or instability. Typically, one will see radiographic improvement within a year, and day bracing is needed as you need gravity for results. Operative treatment, namely a proximal tibial osteotomy, is indicated in kids greater than 3 years old. Some people use an old-style pins and plaster technique. If there is a bar seen on preoperative MRI, one must resect this, and osteotomizing the fibula is really key to gain correction. You want that distal fragment to be in slight valgus external rotation, which will also laterally translate it. Adolescent Blounts is also unfortunately called fat thigh syndrome. Full leg length views to assess the overall deformity and all places of deformity are really paramount for appropriate treatment. They tend to have less medial joint line depression than the infantile blounts. In fact, if you see a lot of joint line depression, one must think about whether or not the child has had this from the time they were very young. An evaluation of the mechanical axis is really critical. There's no indication for bracing in these patients. Your goal is to restore the mechanical axis. Hemihypertrophy adductus has been discussed in less severe deformity that you catch quite early, but they can have an unpredictable varus rebound. Osteotomy correcting the varus procurvatum deformities is really the standard of care. Most surgeons will perform an anterior compartment fasciotomy, and you also want to correct the distal femur at the same time if possible. Hemihypertrophy addutus requires greater than 2 years of growth. Typically, most people will address the tibial deformity with a gradual correction with an external fixator, although acute corrections are also occasionally done for lesser deformities. Tibial bowing, this is often tested. Anterolateral bowing is a result of neurofibromatosis in many cases. Anteromedial bowing is associated with fibular deficiency, which used to be called fibular hemimelia. Posterior medial bowing is the most benign. It's typically secondary to intrauterine positioning, resulting in a calcaneal valgus foot. The only thing to know is that they can have a leg length discrepancy at maturity of 3 to 4 centimeters, and so they do need to be occasionally followed. Neurofibromatosis, while this has various orthopedic manifestations, I will focus just on the bowing in this lecture. Your goal is really to prevent fracture. The deformity does get worse with age, as does the risk of having a fracture. You want to put the child in a total contact clamshell brace essentially forever, from the time they start walking, to prevent further bowing and fracture, and there's very good evidence that bracing does lower the fracture risk. They do get a pseudoarthrosis, they do not heal properly, and often these kids need an osteotomy and grafting if they have a progressive deformity. Free fibula graft is quite common with these, and intramedullary versus external fixation can be performed. They are terrible healers, and so you want to prevent the fracture to begin with. They also, of note, have a dystrophic scoliosis, resulting in short, sharp curves. Fibular deficiency, which used to be known as fibular hemimelia, is an absence of part or the entire fibula, but it does affect the whole limb. So you also want to look out for PFFD, hip dislocations, ACL deficiencies. They can get a pretty significant lateral femoral condyle hypoplasia, which can give them valgus. They also get a ball and socket ankle and absent lateral raise of the foot. Typically, we use the Achterman and Calamshi classification, and this is provided just to show you the different ways they are treated. So our first picture here shows a type 1A, which is when a portion of the fibula is present, but the proximal fibular epiphysis is distal to the level of the proximal tibial physis. And when it's present, the distal fibula is proximal to the talus. So they do get a valgus-looking foot. You can put a heel lift in and sometimes lengthen them, but in many cases treatment's not needed. For a type 1B, they can have a partial absence of the fibula up to 50%, and typically the distal portion of this is unable to support the ankle. Contralateral epiphyseal adductus can be helpful, as well as limb lengthening. Often a supramalleolar osteotomy is needed to correct their ankle valgus. And type 3s, there's a complete absence of the fibula. This often requires multiple procedures to equalize the leg lengths and achieve a stable ankle and a plantar-grade foot. Foot ablation and amputation is also considered in these patients if they have a very small foot with few rays. Tibial deficiency, also previously known as tibial hemimelia, is an absence of part or all of the tibia. It's associated with preaxial polydactyly and also ulnar aplasia. And really the stability of the knee and active knee extension determines treatment. I put the classification in here just for completeness. You will probably never be asked about this. But what's important to know is that in some cases, you do not have enough proximal tibia to allow for an appropriate extensor mechanism, which does play into treatment. So knee disarticulation is considered when there's no tibia or when there's so little that the child achieves very little or no active extension. If there is some tibia and active knee extension, you can consider a synostosis with a modified sign. and CIME amputation is the standard of care for distal diastasis. Chugging on down the line to the foot, let's talk about clubfoot. You want to correct them in this order: cave, referring to the cavus, adductus, varus, and equinus deformities. First ray dorsiflexion is really key to maintain in order to appropriately line up the foot. And you want to make sure that you're rotating at the talar head, not at the lateral malleolus or at the cuneiforms. A thorough physical examination is paramount. There are many conditions that are associated with very difficult to correct rigid club feet, including arthrogryphosis, diastrophic dysplasia, myelodysplasia, and tibial deficiency. At the right, you can see what the series of Ponseti casts look like, as this is the standard of care, and bracing until age 4 is necessary to prevent relapse. Posterior medial release can be performed at the age of 9 to 10 months if needed, and is typically needed in children that have syndromic club feet. Tibant transfer can be considered at the age of 4 years old for dynamic supination. Metatarsus adductus is typically a packaging disorder. What you don't want to miss is evaluating the hips. All of these children should have a hip ultrasound to evaluate for concomitant hip dysplasia. It's also associated with torticollis. Often these are passively correctable and will spontaneously resolve by the age of 4. Congenital vertical talus is often thought of as the opposite deformity of a clubfoot. It's an irreducible dorsal dislocation of the navicular on the talus. Typically, these babies are born with a rigid flat foot. You can sometimes see a rocker bottom deformity. 50% of these children will have other abnormalities. So for you guys, it's important to know that they need a very thorough workup. Arthrogryphosis, spinal muscular atrophy, spina bifida, and diastomatomyelia are all associated with congenital vertical talus. The important thing also is to rule out an oblique talus, and these can be further characterized on a forced plantar flexion lateral view of the foot. In a normal foot, one would expect the first ray and the talus to be aligned. In an oblique talus, in the forced plantar flexion view, the talus will line up with the first ray. In congenital vertical talus, nothing will reduce that talus, and that's important to note. In terms of treatment, casting with the reverse Ponseti method has been considered the standard of care. Even though most of these children need surgery, it can lessen the amount of releases they will need. At about 6 to 12 months of age, most children will require a talonavicular joint reduction and pinning. The peroneals and Achilles sometimes need lengthening. Occasionally, these patients will present late, especially in children with neuromuscular disorders such as cerebral palsy, as evidenced by the X-ray on the lower right. Talectomy is a more appropriate procedure for these patients. Cavovarus foot is covered under the neuromuscular lecture. Tarsal Coalitions, calcaneal-navicular is the most common, and these children will typically present between the ages of 6 and 12, and they'll have pain in the sinus tarsi. Older children will present for talocalcaneal coalitions, and they'll typically have pain under the medial malleolus. They'll present with a flat arch and a valgus hindfoot. They have very limited subtalar motions, and often they'll give a history of frequent ankle sprains. You want to get a CT to clarify, and also to look for other coalitions, which can be quite common. You always want to try non-operative intervention first, which includes 3 to 4 weeks of casting, as well as UCBL orthotics, and occasionally physical therapy for Achilles stretching and proprioceptive training. If children continue to be symptomatic, then you could go forward with a coalition resection with interposition grafting. There is no evidence that one graft works better than the other. People have used fat, they've used a sliver of the EDB, and also bone wax. In studies, these have all shown to be equivalent. You only want to undertake resection if less than 50% of the joint surface is involved, And it's important to note that only 80% of patients get complete pain relief from resection, even when a good resection is done, which is why non-operative intervention is always tried first. Accessory navicular is a big cause of medial arch pain in the pre-adolescent and adolescent population. It's thought to be from an inflammation secondary to overuse and posterior tibial tendinitis. As a first-line treatment, activity restriction by shutting them down in a cast, and then transition to a UCBL. Operative excision is not undertaken lightly, as up to 20% of patients can still have pain postoperatively. Additionally, you do not want to advance the posterior tibial tendon, as this can lead to increased morbidity. Brachymetatarsia is more common in females than in males by about 25-1. It is a strong genetic component, and again, other than being cosmetically unsightly, the important thing for you guys for the exam is that it is associated with a lot of other conditions, including Down syndrome, Turner syndrome, Larson's, and dystrophic dysplasia. If it's very painful and the kid has been resistant to shoe wear modifications, a metatarsal lengthening can be undertaken, but this is often not needed. Bracket epiphysis. This is evidenced by a delta phalanx, which can sometimes be very hard to pick up on initial x-rays. Children will often come in for concerns of a curly toe or a toe that is unsightly. The involved bone can be trapezoidal or triangular, and that's important to notice so you don't miss this because it will worsen with age. Taping and non-operative interventions are often not effective, and epiphysiolysis is needed in order to completely correct it. Now that you've had a big whirlwind, go take a break, and good luck with studying.